How fantastic to see everybody here. I would never have thought earlier on in the year we'd be in a large room all together at conference. So it's absolutely fantastic to see everybody. For my sins, I'm Simon Love. I'm the chair of National Back Exchange and will be for another year. So unfortunately, you're lumbered with me. Anyway, let's crack on. So some housekeeping, guys. If the fire alarm goes off, I suspect you just need to go outside and get drenched, and that should sort of sort everything out. I don't think you need to do anything else. However, in the process of getting drenched, if you can make your way to the exit gate, there's a barrier there, and that's the fire assembly point. So if it goes off, we just have to move. The conference app is up and running, so if you haven't downloaded it, could you please download it? Because there's lots of interactions there that I'll be talking about a little bit later on. If you've got any problems with the app, and I had a slight problem this morning, I downloaded iOS 15 and it doesn't seem to like it very much. So if you've got any problems anyway, could you just go to the membership area, which is almost directly opposite the doors there. That will be manned all today and all tomorrow. If you've got any problems of any sort, please see any of the Echo team who would be more than happy to help you out. There will also be a member of the exec there at every break. So if you've got any questions about National Back Exchange or any queries about anything, please approach us. We'll make sure somebody's there all the time. The workshop selection is quite important because we have limited numbers for the workshops. And we can't exceed those numbers for fire regulations. So if you've already indicated your choice and you can't remember what it is, then could you please go to the desk and they'll inform you exactly what workshop you put down for anyway. If you haven't made a selection, I'd highly recommend you do, because if you don't, you may not be allowed into the workshop. So you can do that at any stage, just see any of the team there and they'll sort you out with your workshops. As part of the awards that we are going to be presenting at the very end of conference would be the Best Workshop Award. So you can score the workshops on your app from 1 to 5. And please do that. Please interact in that way so we can award the Top Workshop Award. And there's also an Industry Innovation Award, which you will notice that the Launchpad area has various people, various companies giving displays during the breaks. Again, you're able to vote for those on your app, and at the end of the conference, we'll be awarding the Best Innovation Award. So please interact with us that way. That would be brilliant. Those of you here for the first time, hands up, those of you here for the first time. Wow! How fantastic, great. We've got a special thing for you on the mezzanine floor in the rotunda. So if you go uphill from here, out the doors, go uphill to your right, and then you go up any of the flights of stairs and you get to a mezzanine floor. And we've got a welcome sort of, not do for you, but we'd like to welcome you to conference and talk you through things up there. And that's at the first break. So if you'd like to make your way up there, that would be great. And we'll see you all there and introduce ourselves. The AGM, which was held last week, was not quorate, unfortunately. We need an AGM because we need to ratify the posts for the following year, and we need to sign off the accounts and various other things. So we do need to get that AGM out of the way, if you like. It's not affecting the running of National Back Exchange because the present executive committee will continue to run until the EGM, which is going to be held on the 20th of October, at 1 o'clock. If you recognize that that may be difficult for you, we'll have some voting forms, and you can vote here at conference today or tomorrow, and you can cast your votes on paper. We'll count those votes up, and those will count towards the final tally. So please, if you haven't voted, could you do that at some stage during conference and just go into the members area, grab a piece of paper, it'll be there, fill it in, job done. That would be great. We'd also like to see you at the EGM, which is on Wednesday, as explained, which is the 20th of October. I'm going to ask Carol just to stand up just for a second, wave her hands about madly like she's drowning somewhere, you have to imagine. This is Carol. For those of you who don't know Carol, she's been the column editor and done an amazing job over the last 7 years. She's been producing column, which is absolutely amazing. She's standing down, and so we would like to find a replacement for Carol, although that's obviously impossible. Nobody can replace Carol. However, she will be giving anybody of any interest the information that you may ask or the questions you may want to ask her, and she'll be at the membership stand. She'll have a seat there with a laptop, and she can talk you through everything during breaks today. So if you've got any interest in doing that amazing job, then please ask Carol and she'll be there to answer any questions. Yes, sorry, COVID. Social distancing seems to have gone out the window. I met somebody I haven't met for ages on the corridor, gave each other a hug, and she said, "That's social distancing gone." Masks aren't obligatory. It's up to you what you feel comfortable with. So what I would like you to do is to respect other people. So if they're wearing a mask, or you come towards them doing a great big bear hug and they offer you an elbow, that's just fine. Let's respect how they want to do that and how they want to manage it. I would encourage you, if you're in very crowded places, potentially to wear a mask if you're comfortable doing that. So we just need to be aware of that. There's lots of hand sanitizer all over the hotel. So if you have the opportunity, just keep good hand hygiene, please. That would be great. And that's it. Conference dinner and awards, which will be held in here tonight. We've got a conference dinner plus the awards. If you've got a ticket and you can't go or don't want to go, could you please go to the members area because somebody else may be able to join conference dinner. And that would be a waste of a place. If you'd like a ticket, no, that's not it, because the tables are full. Okay. All right, so if you've lost your ticket, please see the membership area, and if you can't go, please inform them. I would like to thank all our sponsors and exhibitors. It's fabulous to see the exhibit areas full, particularly the conference partner, Stryker, who've done an awful lot towards the conference, and the platinum sponsor, Lynette. I'd like to thank them specifically. But actually, everybody who's exhibiting, we are a symbiotic relationship. We need the exhibitors and the sponsors. They need us. We need to work together. So if you get the opportunity at break time, please go around and have a chat and see what's new and engage with them, because they've put a lot of resources into exhibiting here, and we'd really like them to get the benefit of that. Jules, I'm really sorry. This happened a few years ago, and I do apologize. However, it is Julia and I's 35th wedding anniversary today. And I'd like to present you with a bouquet of flowers. It's been the happiest last 35 years of my life. Very good. Ah, isn't she pretty? So, on to business. We've got a fantastic program lined up for you. The vast majority of that was created in her last year in post as conference speaker by Carol Hucknall. Carol, is Carol here? Hi, Carol, thank you so much. You've formed the basis of what we're doing this year, and it was a fantastic help for us, particularly when we're on our own and we needed to take up the reins of everything, so thank you so much for that. And the first speaker today is Jackie Fletcher. I had a word with Jackie in the corridor. I said, "Jackie, how do you want me to present you to the conference?" She says, I'm just a nurse. She's not just a nurse. I'm sorry, Jackie. I will just read a little bit of your blog to give them an idea. You're currently an independent wound care consultant and senior nurse advisor for Stop the Pressure Programme, NHS Initiative Improvement, and editor of the Wounds UK Journal. So anybody knowing about wounds, it's got to be Jackie, which is great. And I've always had a passion that manual handling has to be linked inextricably with pressure ulcer prevention. So I'm really excited to hear what you've got to say, Jackie. So if you'd like to welcome Jackie to the stage. I seem to have used up an awful lot of space here. There we go.
Good morning, everybody, and thank you so much for inviting me to speak at this event. It's a real pleasure to be speaking somewhere different than wound care, where everybody knows what you're going to say. Hopefully you guys don't know what I'm going to say. And it's great to think that we might be working more in a team. Although I imagine lots of you already work with your tissue fibrillity nurses anyway, I know it's quite a good relationship around lots of elements of care. And certainly in lots of organisations, we are seeing a move to bring specialist teams together under a harm-free care banner. So we are having leads that lead a team of harm-free care specialists, which might include moving and handling, tissue fibrillity, infection prevention, falls. Have any of you got that kind of a system in your organisation? So it's lovely for me to be here, but actually I'm quite nervous. It's the first time I've been out for 2 years. My knees are complaining because I've put heels on and I've had to print myself some notes out, which I never do, just because it feels unusual. Because we've done lots on Zoom, but when you're doing it on Zoom, you can see everything on your screen and you've got everything around you that you need. So let's hope it goes okay. And it's an hour, which is quite long, so hopefully you will bear with me. So what I really want to do today is to try and make those links. I'm hoping most of you know them anyway, but I think it's important to go through them and really pull them together and then talk a little bit about equipment. So when at my conferences, when we talk about equipment, we're nearly always talking about mattresses and cushions. And the other bits of equipment get forgotten quite a lot, but I think they're as important, if not more important. And as well as all the moving and handling things, for me, two really important things that get forgotten in terms of equipment are bed frames and the chair, not the cushion or the mattress, the bed frames and the chair, because they really make a difference to what we can do. So currently in England, and my introduction says I work for National Wound Care Strategy. That's an English initiative, so it's part of what was NHSE, came under that auspice. So everything I will tell you about is work that we're doing with National Wound Care Strategy. And is anybody here from Scotland, Ireland or Wales? I'm really sorry. This is an English initiative, but I know I speak to the teams in Scotland and Wales and Ireland, and they are looking very closely at what we are doing, and you will have something very similar. So the definition of a pressure ulcer has not changed for some time. These organisations at the top, which I from now will refer to as the international guidelines, are the National Pressure Ulcer Advisory Panel, which is America, the European Pressure Ulcer Advisory Panel, which is Europe as we know it, and PPPIA is the Pan-Pacific Pressure Injury Alliance, which is Australia and Japan. The Americans, they don't like to do things simply. They've changed to NPIAP, so they're now National Pressure Injury Alliance Panel. But I'm just going to call them the international team from now because that's too much of a mouthful. In terms of the definition, important parts about this is it's localised injury to the skin and underlying tissue. It talks about bony prominences, it talks about pressure, and it also talks about shear. But in the confounding factors, you'll notice they only mention 2 consistent things that apply. And I guess these things are important to you guys as much as they are to us, and those are impaired mobility and sensory perception. We always like to play with things a little bit when we create national documents. So when we did a definition and measurement document, which was published initially 2017 and revised 2018, the only thing we added to it was something around medical devices, because that's not included in the generic definition. So you can see there's that bracketed bit in the middle that talks about pressure ulcers also occur underneath medical devices. And certainly, I'm guessing in your organisations over the last 18 months, you've seen those skyrocket as we have increasingly put masks on patients, increasingly prone to patients, they've got things stuck underneath them. It has become a problem. So we were doing quite well. Pressure ulcer prevention has been quite high on the political agenda for a long time. Most of you will aware there was a Stop the Pressure programme started in 2011. We had patient safety thermometer, and we saw quite a good reduction in pressure ulcers from nearly 6% down to 4-point-something%. But actually, once we got there, it just kind of stopped. and we're still seeing quite a lot of patients developing pressure ulcers. And we did a piece of clinical audit work in 2018 and 2019 where we audited 18 organisations, 23 hospitals in those organisations, and over 10,000 patients. And we physically examined every single patient. So this isn't a documentation review, this isn't asking the nurses. We went and examined every single patient's skin. So we are confident that the number of pressure ulcers we are talking about are true. And you can see that what we're looking at is an overall prevalence of 9.04%. That's 1 in 10 patients getting a pressure ulcer, which is not good. Now, that's double what safety thermometer was, and you might be thinking that's shocking, but actually we know safety thermometer wasn't that accurate, and one of the reasons it has stopped is because it wasn't that accurate. And when we looked at what other people had found, so we did some work when I worked in Wales, it was very similar. But for me, the most important thing is that bottom line. Individual trust proportions range from 3.9% to 27.7%. Do you find that quite shocking? I do. Now, there was a mixture of hospitals. There was big hospitals, small hospitals. We had a couple of specialist hospitals. We would expect a little bit of fluctuation, but not that much. We also know about costs of pressure ulcers, and this table, which I appreciate there's a lot of information on, is from a huge piece of work called the Burden of Wound Study, and it's run by an economist whose name is Julian Guest and a big team. And this is not real-world data, as in they don't collect it prospectively. This is retrospective data analysis from GP records. So you can imagine what the caveat around that might be. But what he said is actually pressure ulcers, in terms of wounds, only account for between 7 and 8% of them. The majority are lower limb wounds, around 41% are leg ulcers, and moving and handling challenge in themselves for many of our patients with massive legs. But if you look at the costs of those patients, you can see, given the percentage, it's quite high. And the cost, if you look along the red box, for a healed wound is £90 million, but for the patients with unhealed pressure ulcers, it's £481 million. And that's because we know we almost have our focus wrong. We spend so much time doing prevention and ticking boxes and datexing and risk assessing that once a patient gets a pressure ulcer, we kind of go, well, we did our job and we did our best. And then they can have a pressure ulcer for 20 years and nobody really worries. But actually, dealing with that patient when they've got a pressure ulcer is incredibly challenging. And I'm going to give you an example of a patient where that was the case. So across the board in England and many, many other countries, we've adopted a bundle approach to pressure ulcer prevention. And I guess you're all familiar with bundles. Since about 2009, we used the Syskin bundle. Syskin's easy because you can do this with it because it's only got 5 letters. And when it was just Syskin, it was surface skin, keep moving, incontinence and nutrition. When we reviewed it, when we restarted the Stop the Pressure programme, we felt there were some things missing. Assessment of risk, we felt should be in there, and some element of communication. So we've updated it, and it's now called asking. And we changed the elements of the S. We put skin inspection before the surface because we feel it's more important that you check the patient's skin, that you focus on the patient before you focus on the equipment. And the giving information is not just giving information to the patients, it's this kind of communication. It's communicating with the team, making sure that everybody is involved in the patient's care. And the basis that we did this is we've had some really good updates in terms of those international guidelines. So we had the first update in 2014 and a more recent one in 2019. And these guidelines now are kind of a big industry, an international activity, and we have commissioned for them proper systematic reviews with guideline groups working on every element of prevention and understanding, including the pathophysiology. So this work on risk has been done by a team and a big systematic literature review as part of a lady called Suzanne Coleman's doctoral studies. And what they've identified are factors that instead of us making up a risk assessment tool and saying, oh, actually, I look after these patients, and I think it's patients, I think it's old patients that get pressure ulcers, they've looked at the literature and pulled out the things where there is a direct causal relationship. And when I was first at TVM, we used to call this intrinsic, things about the patient, extrinsic, things about the environment. But we've changed it, and we now talk in a more scientific language. And we've been forced into that by our working relationship with biomechanical engineers who are doing a lot of the scientific research. So when we talk about these boundary conditions, we talk about the magnitude of the mechanical load, the duration of the load, and the type of load. And in that type, we include pressure, friction, and shear, rather than just focusing on what we used to do, which was pressure. We accept there are things about the patient themselves that makes the difference, but today I want to focus on those mechanical boundary conditions making the difference. So I mentioned the audit and what we're doing in practice. I'm going to show you smaller versions, don't worry, don't try and squint at that. But one of the things we felt was important when we were looking at patients' skin to see if they were developing pressure ulcers is to also look at the care they got, because we kind of wanted to know why they were getting pressure ulcers, what was being done, and what was not being done for them. So just for today, I'm going to focus just on the surface and the keeping people moving, because I think that's the things that are more relevant to you. And one of the things that's really obvious is we use a lot of equipment in terms of pressure ulcer prevention equipment. Now, bearing in mind this is in acute, we haven't yet attempted to do community. It feels almost a job too big. But you can see that almost half of the patients were on a specialist support surface, 46%. Much less had a cushion, even though they were sitting out, and far fewer had heel protection, even if their heels were at risk. And that tells us a lot about challenges of equipment, but it also tells us that one of the reasons heel prevention is less liked is it gives us other challenges in terms of harms. If a patient is wearing heel booties, it's actually likely to increase their risk of falling. It's also quite likely to reduce their mobility and make them more dependent on us. So people are more reluctant to use heel protection unless the patient's in bed. And actually quite a lot of the mattresses we have now have got good heel protection built in. For repositioning, this was quite positive. We found that over 50% of patients had a planned repositioning regimen. Now remember, some of these patients weren't at risk, so 50% is good. And of those where it was appropriate for them to have it, 62% had moving and handling equipment at the bedside. Now, I'm going to be very clear about that. It was present, we weren't checking that it was used. And you will know that in some of your organisations, part of preparing the bed space is checking that the slide sheet is readily available. It doesn't mean that it ever makes it near to the patient. So when we go back to asking, for us, that keeping the patient moving is one of our big activities. But sadly for me, I think that when the majority of clinicians think about keeping the patient moving, what they think about is putting the patient on a mattress. That's the standard answer. If you look at the care plan, it says, put the patient on a mattress. That's not the best way to get the patient moving. It's a surrogate for their movement. It isn't an encouragement for them to get back independent movement. And we do that because it's easy. But it's not the right answer. We should be doing much more to encourage independent movement, thinking about the other things we need to consider, like falls risk, moving and handling risk assessments. Even thinking about moving not just as a nursing task. And one of the challenges we have in our repositioning schedules is that they're not true. They're absolutely not true. Because we tend to say reposition the patient every 2 hours, we'll have a chart, a turning chart, repositioning chart, whatever your organisation calls it. And patients are turned at 12, 2, 4, 6. What, all 6 of these people in the bay are all turned at 12 o'clock? That's utter nonsense, isn't it? Utter nonsense. And if you've got electronic patient records, it's even worse, because you'll find every patient in the bay is turned within a minute of each other, because the EPR is not at the bedside, so they deliver the care, and then they go to the computer, and it timestamps it now. We also know that if we're doing a root cause analysis of what happened to a patient, why did this go wrong, there might be gaps in the repositioning. And when you start to investigate, why was that patient not repositioned? Oh, they were with the physio. The physio was walking them on the stairs. Do you not count that as a reposition then? You've taken them out of the bed and you've got them physically upright, there's no pressure on their bottom, but it's seen, the documentation is seen as a nursing piece of paper. So we don't get people, other than nurses, writing what movement they did with the patient on the document. So actually, you could have just repositioned a patient 3 minutes ago, and the physio comes and takes them out of bed and does something with them, and then they put them back into bed in the position they were before you repositioned them. So you're putting them back on the area that was at risk. So we need to get much better about understanding patients' activities and the need for repositioning. We also need to think for patients about the importance of sleep. And I don't know if any of you over the last 18 months have found it harder to sleep. I know lots of people have. People's brains have been busy. People have been worried. But if you have disturbed sleep, it's not good for you, is it? Yet we quite happily go and reposition patients every 2 hours when they're quite sick and they maybe need to sleep. So we need to think about alternative ways of doing that reposition that might disturb the patient less. So whether that's using automated repositioning systems, whether it's thinking, do they actually need turning every 2 hours? Let's have a look at the skin once we've done the reposition and see if we can push it to 3. If the patient in their sleep is kicking pillows out of the bed, how many times have people said to you, I've repositioned this patient on these pillows and they pull them out? What does that tell you about the patient's level of activity? It tells you maybe they don't actually need those pillows because they're quite mobile. We also don't use enough other positions. We're obsessed. I know you've got a session tomorrow by Joe Swan and the team from Birmingham talking about their tilting mechanism. And how many of you sleep like I do, like this? Yeah? Recovery or some version of recovery position, almost on your front. Have you ever seen a patient put in that position? Apart from now when we prone everybody. But it's a great way to get the patient off the bottom, isn't it? So in terms of keeping the patient moving, we're encouraged to mobilise regularly, but nobody says what that regularly is. Nobody says how much of a move is a reposition, and I'm going to show you some pictures. And nobody says what other things you can do that will help the patients become more independent. So I had a relative who was in hospital, I was going to say recently, but it was pre-COVID, so it's quite a while ago, and had been in intensive care for quite a long time, and got told off by a physio because I was doing passive leg exercises with him. Now, when I was a student nurse, if you didn't do passive leg exercises on a patient that was bedbound, yeah, you were shot. You were in big trouble with the nursing officer. But the physio told me I was wasting my time because it was pointless. And I started to have a conversation with her, and I was trying really hard to be relative. And she started telling me about the evidence behind passive movement. And I said to her, what you don't understand is his leg is really stiff, and when we move it, it hurts. It's not about regaining function, it's about pain. So if I do this every time I visit, it increases that mobility. And she was really upset at me, and she was then put him in quite a fixed splint, and every time I came, I took the splint off, did him some exercises, put the splint back on, because that's what you do, isn't it, when you're But I think some of the things we used to do, we stopped doing. I would ask you, next time you go into hospital to see a patient, or if you're acute anyway, talk to staff about long-term patients. How often do they do that kind of activity? But we know about loss of muscle mass. We know that patients in hospital lose 10% of the muscle mass really quickly, but we don't do anything to benefit that. With my colleagues in lower limb work, actually, they get a lot of, the stretchy elastic bands for exercising lower legs, because calf muscle function is really important in lower limb care, but we don't seem to think it matters in pressure ulcer prevention. But actually, it's a great way of maintaining that movement of the limb, helping that patient maintain their independence and getting them engaged in their own care. Because it's not just about moving their foot, they're moving their arms, they're moving forward, they're putting effort in, it's increasing the respiratory move. Some of the things I get said to me, though, is when we say about repositioning the patient is we can't move that patient. We can't move that patient because they're too big, I haven't got enough staff. We can't move that patient, particularly in intensive care, because they are unstable, and I will get this, what do you want me to move them or them to have a cardiac arrest? I'm like, well, I'd kind of like them to not get a pressure ulcer and not have a cardiac arrest. That would be good. But there's a perception that a movement is this, when it can just be that. And a small movement that actually redistributes the pressure can be enough if you do it frequently enough. No equipment, constant theme. Is that something you hear all the time? We haven't got any equipment, or we haven't got the right equipment, or the equipment's in the wrong place. And that's why, like, slide sheets are put in bed spaces now, isn't it? Because if they're in that cupboard over there, we'll just grab them and do it. I understand about patients being in pain, but what are we doing about to manage that pain? Are we using appropriate analgesia? Are we using the right equipment? Are we preparing the patient? Some pain's anticipatory. They've had a bad experience of being lifted before, put into a hoist and it being scary, and they don't want to do it. And equally, at patients' end of life, do we want to be repositioning them? Is it dignified? Is it in line with their wishes? Is it in line with their wishes to die with a horrible, smelly wound that hurts? The other thing that frustrates me a lot is I will see patient repositioned, and the reposition is they were sat in bed and now we've sat them in the chair. That's not a reposition, is it? It's just a change of scenery. And it kind of shows the lack of understanding about what the purpose of a reposition is and what they're hoping to achieve. So, in terms of keep moving, the other element that gets forgotten is the hypermobile patient. And we have quite a high number of these who have too much movement, they're fidgety, and that may be something like dementia where they're constantly moving and you almost feel you have to come. In my student nurses days, does anybody remember Buxton chairs? Yeah. So if you're young, a Buxton chair is an armchair that you could tip right back and you could force a tray table on it. So basically, you were imprisoning the patient in the chair. But it was often quite a little old lady, a little old man, and all they just did was slid under the tray table and get caught by the chin, which is, again, not very safe. So we have better solutions to that now. But you get patients who are fidgety, patients who have tremor, patients with confusion. And in terms of skin harm, actually, that can cause as much, if not more, skin harm, both pressure damage and things like skin tears. So we need to look at appropriate solutions for positioning those patients and manually handling those patients that doesn't cause them distress. The positions we use sometimes cause us discord with other elements of the team. And as I said, Joe's going to talk about the 30-degree tilt tomorrow. But when we reposition, we used to put the patient on their side, on their back, on their side, and back through that cycle. And we worked out quite quickly that what we were doing in doing that is putting the patient onto a large bone, and actually the bones are the areas that are most susceptible to pressure damage. So a system called the 30-degree tilt was instigated, where you use cushions, wedges. Wedges are really good for this, pillows if you happen to have any, and they're not the typical hospital ones where all the filling goes to either end of the pillow and you just have material in the middle. And what you should be doing is tipping the patient onto a large muscle, onto their buttock. And you should be able to touch both hips. You should be able to slide your hand in and touch the coccyx. You should be protecting the legs, so both knees are protected and all four malleoli are protected. You have to make sure the patient is comfortable, because you don't want a patient whose hips are over here and their body over here. That's not comfortable, so you have to support the patient well. We also don't want the head of bed elevated more than 30 degrees. If you lift the bed head more than this, you increase shear. Now, if the patient's got a bad chest, they want to be like this. So respiratory patients always challenge our management of biomechanical forces. ICU patients, ICU want a minimum of 30 degrees because they don't want patients developing chest infections. So there's this constant tension between keeping shear forces low and allowing the patients to breathe. And I think breathing generally wins, but it just means that we have to think about the skin a little bit more. So in terms of joining the dots for all those other disciplines that we work with and all those specialist areas that we work in, because I think we tend to get really focused on our practicalities. My guys are always looking at the mattress. It's always about the mattress and the patient's position. We need to think much more about why we're doing some things. We also need to understand why that moving from the bed to the chair is not right. And that means we need to understand the science, and we need to start working across all different disciplines and all different types of therapy, so that we don't have the physios doing this for them and then somebody else coming to do that for them, and then we go and do this and it undoes everything that they've done, or they undid everything that we've done. So don't worry, there's not too many cartoons, only 3. And I think at the minute, the changes that we saw in COVID, the positive changes where people were redeployed into... Did anybody get redeployed to somewhere really random that you'd never had any experience of? So we had a lot of children's nurses working in our leg ulcer team. They were very scared. Please don't make me do this, please. What else can I do? Can I just do the paperwork? No, you need to learn to do this. It's quite easy. But it made us realise that actually you can slide about, and that you can get support really easily digitally. So if you're with a patient, even if you're in community and you're out there on your own and you don't know what to do, you can press a button and you can video, and somebody else can look at that patient and you can brainstorm what's the right way to manage this patient. So I just briefly want to talk about the mechanical load thing that we talk about in pressure ulcer prevention. So for our TVNs, mechanical load is something that's quite challenging to them, because generally we are nurses, we are not biomechanical engineers, and not everybody likes science and not everybody takes to it easily. And people sort of understood pressure, because you could go, if you put pressure on like that, it stops the blood going through, things die. That's quite easy, isn't it? It doesn't need a lot of explanation. You don't need fancy diagrams. But when you come to shear and friction and microclimate, you're suddenly starting to talk a new language. You're having to really think about what else is going on. And for me, it's that what else is going on, that clinical curiosity that's missing for a lot of people. So when we go to our root cause analysis or to our safety panels about why did this patient get a pressure ulcer, you will find the answers are normally like 3 words. I don't know, is quite a common one. And they didn't, when they discovered the pressure ulcer, say, right, hang on, before I do anything, let me just look at this environment that this patient is in. Let me investigate a little bit what's happened here. Whilst nothing's changed, let me look. And an example I can give you is, whilst this relative was in a different hospital with a different problem, because they're quite decrepit, he was in for vascular reconstruction. So he's on the vascular ward. And in the bed next to him was a youngish guy, I'd say late 30s, early 40s, diabetic, above knee amputation, first above knee amputation, lost a couple of digits on the other toe. And again, I'm trying to be relative, trying really hard not to look at this man with his above knee amputation, sat in a wheelchair, that the armrest like this, the down bit was digging in his leg so much. And the staff's answer to it was to bandage round the bit so it stuck in his leg a lot more. And I had to say to him, look, I'm really sorry, this is what I do. Would you mind popping back on your bed, because I'm very worried about your leg and I am going to go and get the ward sister. And they were really affronted. And they said the tissue viability nurse had told them to pad it to prevent further damage. So it tells me that their but why is wrong. Do you see that in moving and handling? Some of the things people do are just beyond your comprehension. I'm glad it's not just us. So, I've tried to simplify what we teach about pressure, shear and deep tissue damage. And with the latest set of international guidelines, this thing about a deep tissue injury has become far more accepted in terms of what the conversations we're having, and an understanding that a lot of the damage happens deep near the bone. Now, when I was a student nurse, we would talk about 2 types of pressure sores or bed sores they were then, and there was ones that happened on the skin, outside in, and there were inside out ones that happened near the bone, and then that fell by the way. But actually now the biomechanical engineers are MRI scanning patients, and we are seeing this kind of thing happening. So we know we've got compressed tissue squashed, and that's due to pressure, or it may be due to shear, and that causes problems with the vasculature, reduced tissue perfusion, and that causes localized edema. But the bit we missed out previously were the changes in cell metabolism. We missed all this waste product accumulation out, and the cell pH changes that are going on, and this acidic environment, and the cell death. And this focus on pressure really stopped us thinking about what other things can happen, because pressure causes shear. And if you are not entirely clear about shear, I'm sure you probably are because you use hoists, the big thing for us now is talking about deformation. So we talk a lot about deformation-induced pressure damage as much as we talk about pressure ulcers, because deformation causes cell death much more quickly. We talk about ischemia causing pressure ulcers as quickly as 2 hours, but deformation damage occurs within minutes. So in terms of maintaining our patient's skin and keeping them healthy, we need to think about deformation. And friction is missed out now of the pressure ulcer definitions because it's not a direct cause, but friction causes shear. So we put it in when we discuss it. So this sustained loading, which causes distortion of the cells leading to death and necrosis, is actually the most important thing for people to understand. So if I said to you, can you demonstrate me friction? You guys know this. How many of you would do this? Yeah. So friction is commonly described as the resistance to motion in a parallel direction relative to the boundary of the two surfaces. Shear is a parallel force, so it's not a direct application, it's moving things sideways, perpendicular to the loading force of the tissues, and it can also refer to distortion or deformation which occur as a result of shear. So when we think about a typical patient in a bed, so this is semi-recumbent, this is the most common position you see a patient in, we have this diagram. This diagram has been around since the 1970s. It's been redrawn and made a bit fancier, but actually this has been around an awful long time. And you can easily understand this for yourself about how tissues move. And when we're teaching students, what we say to them, if any of you want to try this, you can. If you sit up nice and straight for me, this will give you a good indication. Put your hands under your bottom and feel the points of your bony prominences, points of your pelvis. Can you feel that? Yeah, some people can feel them more easily than others. I can't because I have short arms compared to my body length. Now, what I want you to do is keep your bottom very still, but I want you to just do that. Is your bone still on your hand? Or has it? No. That's shear. You can take your hands out before they go numb. But that's what shear does. It keeps the skin static, but everything inside the body moves in that parallel force. So what you can see here is this patient's skin is stuck to the bed sheet. They're probably on a horrible bed sheet. Their night is wrapped around them like this, so it's their bare skin. And they have done what we do. As we relax, you get a bit shorter. If you do a long drive, do you have to turn your mirror down because you miraculously lost a couple of inches in the car? And you can see those kind of wiggly bits are meant to denote how the skin is shunting up behind the patient's bottom. And it's not just the skin, it's everything that's in between that's happening. So the thing that's holding the patient in place is friction. So when we talk about friction as a moving force, it's only telling us part of what we're talking about, because there are two types of friction. There's the coefficient of friction, the static friction, which is the force that resists an effort to slide from one surface to another. I have 3 small grandchildren. Trying to get them down a slide, particularly in wellies, is not easy because you constantly have to lift their feet in there because their wellies don't slide because they're made from rubber. What we see for most patients in that semi-recumbent position is a high coefficient of friction that is keeping them there. Unless they've come in for a planned operation and they're a woman of a certain age and they're wearing their best nightie, which is usually shiny and satin, and then they're constantly sliding down the bed, but the nightie's up here, because that has a low coefficient of friction. What we are talking about in terms of skin harm, though, can be dynamic friction, and I'm going to show you an example later about what damage dynamic friction can do to the patient's skin. So once the patient starts to move and slide, migrates down the bed, as they do very commonly, then we start to see a different kind of thing happening. Both of them can cause deformation damage. So understanding pressure ulcer requires us to look at what's happening in the tissues rather than just what's happening in the skin, and joining those elements together. Now, this is a diagram that's from a technology that helps us to look into the tissues. But I just want to show you the complexity. So if you look at that top red line, that's telling us this is what we see on the patient's skin when they're at risk of or developing a pressure ulcer. Whereas down here is telling us the things that are going on underneath the tissues, which are ischemia, lymphatic dysfunction, inflammation, deformation, reperfusion injury. Reperfusion injury causes lots of damage. You know, if you cut off a blood supply, let it go. Cut off the blood supply, let it go. You get lots of free radicals, free oxygen species being reduced. And you start to see changes above that red line, which is where the damage is starting to occur, above the first red line, for quite a while before you, on the second red line, see them. So you see increases in vascular permeability, you see all that edema that we describe, and if you think about what edema is, that's what we're talking about. So going back to shear, it's about this force parallel to the surface of the object whilst you keep the object still, mainly. But it can occur during dynamic friction as well. And it's very much about this change in shape of the cells. So now we're starting to think at a cellular level, don't just think about the tissues. If all the tissues do that, every single cell in that tissue is also doing that. So shear tends to occur when the skin remains in one place and the skeleton slides down. We've just done that exercise. But you can cause shear just by applying pressure. So this is an example where you see, if you think about the bone pressing on the tissue, so just you sitting nicely, no friction, you're well supported. If you think about those squares, if you think of your cells as squares, putting some pressure on them will change their shape, because they have to move out the way to support your body weight. So what you can see, even on the best bit of foam, the best whatever mattress it is, those internal tissues are starting to change shape. And that changing shape changes lots about the boundary conditions that happen in the body. So what we have is two things happening. We have a mechanical load, and we have deformation damage, and we have ischemic damage. Ischemic damage, really, really straightforward. Once you get to deformation, what you start to see is inflammation. So the cell walls start to become leaky because you've stretched them, you've changed them, and they let out things that are inside that shouldn't be outside. They let things from the outside in. They start to sound out help signals. The fluid seeps out into the tissues. So you get that, when you get edema, you can feel it's hard and swollen. That in itself changes the shapes of the cells because there's not much space anymore, so it increases deformation. And all of this together, particularly if you include the blood supply to help with that, leads to pressure ulceration. So we talk about this vicious circle of events with deformation, an inflammatory cycle where you see all this cellular damage occurring, localized cell death. Even if you think about things just from a pressure perspective, if I've got 3 fingers supporting something and I kill this one, and now these 2 are just supporting it, each of those fingers is now supporting more weight. So the damage to that is more. And you can start to see how this builds up and builds up and builds up. So what we have is this pattern of inflammatory, deformation type damage. You can see where the big bones are. We also know that clinicians are not very good at describing anatomical locations, so we are now giving them diagrams saying your coccyx and your sacrum are not the same thing. Please can you understand your ischia and your trochanter's not the same thing. And you can't just say bottom because it's quite a big area. And buttocks tend to not get pressure ulcers because, that's not really where the bone sits. But you can see on this pressure ulcer at the top how closely that maps the shape of a sacrum. So in terms of clinical curiosity, for me, when I look at that and I think, how did this patient get this pressure ulcer? That's a patient who's been lied flat because it matches the pattern of the bone. Would you be surprised that this patient had fallen at home and been on the floor for 3 days, flat on the back? No, because that's what happens, isn't it? So we need to understand what the different forces look like. And I think particularly in terms of moving and handling, we need to think about what pressure we're causing to patients, if we're causing friction, and if we're causing shear. So this is a wound caused by friction. Can you recognize that? Because this was early 1990s, and this was a quite big patient who'd had a stroke they were edematous, they were clammy, they were confused. It was early days of hoists. Patient didn't like the hoist. It was the middle of the night, and if you tried to hoist them, they woke the rest of the ward. So the two nurses on duty thought they'd Australian lift the patient up the bed. Don't put your head in your hands. It was what we did. It's what we did. We were very good at it. We practiced. But you can see they obviously didn't practice very well because they didn't actually clear the patient's buttocks from the bed sheets. So you can see the static line where the static friction occurred as they dragged the patient up the bed and ripped the surface of their skin off. How painful do you think that wound is? Yeah. Can you see those kind of loose bits of skin as well? How easy do you think it is to get a dressing on that wound, given the position? How scared were people about pulling those bits of skin off? But that shows you that's pure friction damage. That's I dragged this patient up the bed, not down, up the bed, and this is what the damage causes. So when we are talking about pressure ulcer prevention, now we're increasingly trying to get people to think about what they're doing in terms of movement. And, you've probably come up with a longer list than I do because it's what you do. But these are common things we talk to them about. What is it you're trying to do? Have you documented it? Have you thought about the forces you're applying to the patient's skin or through the patient's skin when you are doing that? And think about if it is a reposition or just the change of scenery element. So again, this is your area of expertise, not mine. I got this off Google. I'm quite happy to tell you that. I found a lovely website from HSA, Health and Safety Executive, and it gave me some lovely slides that I'm quite happy to say, this is your area. But I think when we talk about pressure ulcer prevention, it's important that we start to put this slide in because we need to start to say to them, okay, let's talk through these things. What do they do to the patient's skin and underlying tissues? Which of these can you use to alleviate some of the problems of friction and of shear? How can you use them better so that you're not causing skin damage? And some of them are about us moving the patient. Some of them are about increasing the patient's independence. And some of them, I think, are about improving the patient's muscle tone. So I mentioned the elastic bands. And I think we need to get much better at doing that passive limb exercises, positive exercising, so that we promote patient independence as a way of preventing pressure ulcers, rather than thinking it's a health thing that we do to the patients, that we stop the patients getting pressure ulcers. We need to get the patient engaged in their own thing. And that can also be about the postures we use and about functional mobility. And, we're very good. I always say to people when I'm talking about nutrition, and make sure you place the food and drink within reach. But actually, a really good way to get a patient to lean forward is to put things out of their reach. If it was me, put the jelly babies over there, I'd be leaning forward quite often. And I can remember about 10 years ago, I had a little local charity come to the local hospital that I work with saying, we think we've got this really good idea to help you prevent patients getting pressure ulcers, again, about functional movement. And bless them, you just think, where do people get these ideas from? The idea was they were going to come and do manicures for patients, and that the patients would have to lean forward over the table, and that would relieve the pressure on their bottom. And it was a really nice idea, but, how often in a day can you do a manicure on a patient to relieve the pressure on their bottom? Not that often, can you? So we need to be clear about what the link between the equipment we're using is and the pressure ulcer prevention activity. It's not just about what we do, it's about what a patient does and what a patient can do if we enable them. And I said right at the beginning, for me, we think about the mattress, we don't think about the bed frame, and we don't think about the chair. Now, my personal opinion of current bed frames is I really hate them. I think they're mainly not fit for purpose anymore, and in terms of pressure ulcer prevention, they give me more problems than they resolve. Some of you are looking confused by that. I will tell you a little bit more about why in a minute, but the reason I don't think they're fit for purpose anymore is often they're not long enough, and quite often they're not wide enough anymore. I don't know why the standard bed size has not changed since 1966, when Doreen Norton was involved in designing a bed frame. So if you know anything about pressure ulcers, you'll know about the Norton scale, which was 1962. And although our chairs have improved from the Buxton chair, we still seem to not give a good standard chair. So we're constantly looking for add-ons and additions and specialist chairs, whereas what we should have is something that, as standard, does the job. And they don't. They're always the wrong height or the wrong width. They don't have enough support. They have entrapment issues. You know, they're chosen quite often because they match the curtains. And that's not a good reason to be choosing the kind of equipment we're talking about. So I'm guessing some of you probably even wrote this. This is the kind of guidance that we are now starting to build. It's the HSE guidance. But what I want people to think about is how that relates to this mechanical boundary conditions, and start doing some joint teaching and joint work about it. Because it is little things about making sure that all the equipment is size and shape appropriate to equally distribute the load. Is this something you say all the time? Get the right piece of equipment, please. It's about thinking about if your sling is damaged, not only might it break and drop the patient on the floor, but it will have high points of pressure, and the patient's skin will get trapped, and it might cause them a pressure ulcer. It's thinking about when you've got the patient on the sling, if they are looking petrified, they don't feel safe, and they will fidget, or they will not tell you that they're uncomfortable. And that if you put the sling in properly, so again, you will have all seen people get the sling, the legs bit underneath, but they're not quite in the right position, so what they're doing is this, pulling it through. It will come through if I just pull it hard enough. Just lift the leg a bit, and grabbing it. And just doing that grabbing movement has just reminded me, can we stop people having rings and nails? You know, that was standard. People didn't have long nails. They didn't wear anything other than a wedding band. How many people, nurses, do you now see with acrylics and gels? Infection prevention hates it. Tissue viability hates it. I'm guessing you guys hate it. But the correct placement of the sling is really important. It's not just about the placement when you're finished, it's how you get it from being not under the patient to under the patient that's going to cause that localised tissue damage. And I'm loving the fact that you're all just going, Do you know how often we say this? Can we link it to pressure ulcers now, please? Because it is a real problem for what they do. So make sure the patient is comfortable, they are less likely to fidget, make sure you've not got those high points. And the question I always get is, can we link the sleeve in place? Can we leave that sling in place, please? And generally the answer is no, don't. Now I know there are some very specialist hoists where slings do stay in place and there are reasons for it. And there are some situations where it is so traumatic getting the patient into the hoist and on that sling that you might do it for a short period of time. But the biggest question is always when the patient's on the commode, and I know there are specific toileting slings, so I'm not going into the hygiene elements, but if a patient is sat on a commode, they are sat on the worst surface possible for pressure ulcer prevention. 1, it's hard, 2, it's small, and 3, it gives you really high gradients of pressure from rock solid to empty space. So, you know, if you want to leave them on because it's hard getting them on and off, get them off really quickly, please. And then they always say, yeah, but then as soon as you get them to bed, they wee. I know, that does happen. It does happen. Doesn't it happen to you? There are times when you go to the toilet and you sit there, you're thinking, I was desperate, why can't I wee? And then, you know, the minute you walk away, you have to go back again. We need to get better at understanding what our patients' needs are. So in terms of what we teach for pressure ulcer prevention about moving and handling equipment is think about managing the load. Think about redistribution. That's what we always taught in pressure ulcer prevention. We don't relieve pressure very often unless you turn the patient on the face. We mainly redistribute. Think about what's happening. Protect the skin is the second thing. So consider the fabric you're using and what effect it has on friction and shear. If you are struggling to get a leg bit of a sling under a patient, use a slide sheet, put that over it, that helps. It's like that's something that, well, slide sheets are for heels, aren't they? Why would I use it for the sling? Oh, it's really easy. Don't pull the fabric, lift it clear, and if you can, move fabric on fabric. Maintaining independence, I think, is really important. So again, if we reposition patients and we put pillows and wedges behind them, patients don't like it generally. You put them in the position you think is comfortable, not the patient that they think is comfortable. And if they've had something like a stroke, and you put them on the arm that they can move, you can bet your bottom dollar they'll turn back over because they can't move this arm and it scares them. So really think about what's going on. So this is the patient example I wanted to give to you. Have you all seen an increase in patients with contractures? Seems to be a big national issue, particularly in nursing homes. I'm not having a go at nursing homes. But where we were trying to reduce footfall and trying to reduce contact, patients were left in their rooms an awful lot more. We've seen it in other areas as well, in community a lot, and even a few in acute care. And this is a patient I was asked to investigate as part of a police investigation because the relatives were claiming neglect on the part of the nursing home. And actually, this nursing home had really quite good documentation. This patient was repositioned hourly, on the hour, every day for 6 months. Patient was Polish, didn't speak any English, screamed a lot in Polish at the staff. But the repositioning schedule said left, right, back, left, right, back. Now, I want you to tell me, based on that middle picture, how are you going to tip the patient any more left than her legs already are? It's just not going to happen, is it? Unless you move her right over to the side of the bed and hang her knees down the side of the bed, you are not going to be able to lift her pelvis clear of the bed. And this goes back to about a complete lack of understanding. These people who were primarily support workers, not registered nurses, were doing the task. They had a repositioning schedule. They followed it to the letter. Let's not even discuss that it happened on the hour, every hour, including overnight. They were doing what they were told to do. They had absolutely no understanding. And when they were challenged, you can see they've got a whole variety of foot protectors. They had the T-shaped cushion in between the legs, upside down. But they also had the feet stuck together, their knees were stuck together. They just didn't understand the purpose of the equipment and what it should achieve. And I think that's what's happening a lot. We are giving people kit, and put us in that, not just you. We're giving people kit without telling them what it's supposed to achieve. So the options for this patient were around, we could manually reposition them with 30-degree tilts. It's not going to happen. Think about how we're going to try and hoist that patient. You know, that's going to be really complicated. Options would include things like automated turning systems. It's much more gentle. It moves the whole patient rather than trying to lift them. And specific offloading products, so you can see underneath the patient's chin. Again, we see this quite a lot, the chin sat on the clavicle. It doesn't matter how often you turn the patient, that's not going to relieve that. We need to use specific things. And managing pain, the reason she was crying out in pain was because it hurt to move her. You know, and it goes back to the example of doing those passive limb exercises. You know yourself, if you sit in the same place for a long time, you get up and you're like, oh, God. It just takes you a minute to get moving again, and the older you get, the worse that gets. So I said I'd tell you why I hate bed frames. We did quite a bit of work looking at bed frames and their part in friction, because when we did some of our prevalence audits, one of the things I noticed was every time I would go to a patient, their feet were always like that, rammed up against the end of the bed. And I investigated a couple of incidents of pressure ulcer damage where patients had pressure ulcers across all 5 toes. And what it seems to me is patients are sliding down the bed and they're hooking the toes underneath the metal bit to keep themselves still. And we actually had a patient with 5 pressure ulcers from that. And the reason they do that is because the bed's too short, and also that they slide down the bed. So if you have this kind of electric bed frame, and not picking on any one company, it happens with them all, you are meant to press the auto sit feature, which puts the backrest up and the knee catch up. What most people do, and particularly if the patient does it themselves, is they put the backrest up. And if you do it, and we did it, so if you look at these 2 little pictures, that's me, I'm not harming any patients, that's my foot. We put a little bit of tape next to my malleolus, and then my colleague sat the backrest up. My heels bounced 15 centimetres along that counterpane. Do you want to talk about the amount of friction and shear that's going on there? But if you think they've moved 15 centimetres down the bed, Well, that tells you why the patient's feet are always on the bottom, because suddenly the bed's become too short. And I didn't understand this. I just couldn't grasp it. So I talked to some of the engineers, and they said to me, well, of course they do. It's about radius of curvature. I was like... So in the middle of an exhibition, they went and found a metal tape measure and made me stand on the tape measure. And I'm 5'7". And they made me be 5'10". I was really excited. Do you know how to do that? You stand on a tape measure, behind your heel, over here, and you go like that. But the bed is the inside curve. The bed curves that way. So the bed gets shorter, the patient gets taller, they don't fit. So we have this real problem about our bed frames. The patients are constantly coming out the bottom. And the mattress doesn't fit the bed, so they start putting these bolsters on. And because if you put it behind the patient's head where it's meant to go, it falls off. So they put it at the bottom where it can't fall off, but now you've got the heels on the not right mattress. So I'm not a big fan of the current bed frames. I think we need a different solution. I don't know what that solution is, but we need to make it better. We have this constant problem of migration in the bed. And for the clinicians, it's a major frustration. They spend half their life lifting the patient back up the bed. For the patients, when I spoke to them, they said, please don't lift me up, because now my feet are on the bottom, I'm not sliding down anymore, and my bottom was getting sore from sliding. But you can cause lots of skin damage, whether that's getting pressure ulcers on the toes, friction damage and shear damage on the sacrum, or skin tears from banging them. So we need to look at better ways of positioning support so that if we put the patient in those positions, they're stable. And it's that, I think that's one of your areas of major specialties, maintaining a stable posture and postural activities that we could benefit significantly from. So in terms of equipment challenges, it's always the same. It doesn't really matter what kind of equipment we're dealing with, does it? Whether we're in hospital or community, it's about the space, size and shape of the equipment. Fitting it in a hospital bed space can be as hard as fitting it in a patient's own home. And it's about what else you need to give up. You know, even plugs at the minute are tricky to find, aren't they? What the patients will compromise on in their own home. So if you're having to put a specialist mattress and a specialist hoist in, that often means you have to go down to a hospital bed. And if they are with somebody, that means that they're turfed out and they have to sleep somewhere else. And it affects their level of dependence or their perceived level of dependence. Patients don't like having hospitalised equipment because even if they have chronic long-term conditions, the move from I'm unwell to I now need a hospital bed is quite significant. It's an acceptance that my chronic disease has progressed to the next stage. So the patient themselves, yes, of course we need to think about, I've mentioned size, shape and weight. We have to think about where the weight's distributed. So we've got a large patient there, but what about if the patient's had a bilateral amputation? So alternating mattresses don't work with bilateral amputations because the patient's legs do this all the time. They just flip up, particularly if it's above knee. Maintaining dependence and independence. If you give a patient a specialist mattress that means that they can get out of bed but can't get back into it from their wheelchair, it's not going to work for them. And what support do they have at home for it? So in terms of equipment selection, I try and think about setting priorities in a hierarchical way. So the first thing is always manage the risks. Manage what your risks are, and it needs to be appropriate, not just for pressure ulcer prevention. You need to think about what the balancing objectives are. So if you prevent a pressure ulcer but they fall because you've put them anti-friction socks on, or friction prevention socks on, that's not a good outcome. Didn't get a pressure ulcer, oh, but they've broken the hip, never mind. That's not the way we should be thinking. We need to then think about safety. So I've got this piece of equipment. Is it safe for the patient? Is it safe for the team? So patient transfers, moving and handling, electrical safety. Any of you community and you go into patients' homes and they've got those really long things connected to another one, and there's so much stuff plugged in. Fire hazards and practicalities. I say that's the order of priority, but actually, for me, that's the most important priority. Because you can put anything in, and if the patient lets the dog sleep on it rather than them, it's a pointless exercise. So I think pressure ulcer prevention and moving and handling are inextricably linked, particularly the more we've come to understand about shear and deformation. That really brings it together. This understanding of the mechanical forces and what it do to the tissues really needs to be in clinicians' conscious levels so that they are understanding why they are doing something, not just what they are doing. It's not always easy to explain. You know, I can sit with a group of people and just see them going like, what is she talking about? I don't know what that is. But at the end of the day, we don't want this to happen. And we still do see these. So, as a final statement, we have an International Stop the Pressure Ulcer Day. It's always on the 3rd Thursday of November. This year it's on the 18th of November. We'd really like it if you join us. We all, this year, are doing a theme called Love Great Skin, but we will be focusing on each of those elements of asking. So we'll focus on skin, across the week. So if you want to get involved, the Keeping Patients Moving will be on Wednesday. So if you want to join us and tweet lots of things about what you were doing, we would really appreciate it. Thank you very much.
Thank you very much, Jackie. That was absolutely fantastic.
Felt it was a lot,
I've got so many notes here about things that I need to start to pay a lot more attention to, which has been fantastic. I forgot to mention on your app, but you can text a question to the speaker on your app rather than having a microphone or rather than doing it the usual way, which is standing up and asking the question. So if you prefer to type from now on, maybe a little bit late now, please do that on your app. We'll actually pick up all those questions and I'll present them to the speakers from now on. I didn't mention that and I apologize. Has anybody got any questions for Jackie? Have we got a microphone we may be able to use, guys? Thank you. Anybody a question for Jackie? Yes, we have a question down here, Tracy. Can you just wait for the microphone?
Yes, I'm happy to share the slides. It was what I share the slides? The answer is yes.
Yeah, sorry, yeah. Has anybody else got any questions?
Is that kind of what you were expecting?
That was brilliant.
Good.
Absolutely. Yes.
I don't know if you can at the minute, but I'm happy for the organisation to have them and give you access however they do that. Absolutely.
Great, thank you. Anybody else got any points for Jackie? We've got a couple of questions down here.
Getting braver now, some questions have been asked.
Hi, I'm Penny Townsend. I'm a paediatric specialist and work with people with complex needs. And I just wonder where some of this pressure management sits with postural support equipment that we use, such as sleep systems, because I often see people in bad positions and then we put postural support equipment in, but we can't necessarily then use good moving and handling techniques or equipment because the postural support stuff gets in the way. So I just wondered what your thought is in pressure and postural management.
I think if we've got good posture management, then for a start, we're redistributing the pressure as well as we can. And it negates a lot of the fidgeting, the sliding, the friction. It is always a challenge, and particularly with those patients with contractures or strange body shapes, the number of questions. We have a national tissue viability Facebook group. It's a closed group. It's only for TVNs, but we often get questions about, I've got this patient with this strange shape. What cushion, what mattress, what bed? And to me, that's quite siloed thinking. It's about, well, there are people who are really good at this. There are physios, OTs, moving and handling specialists. This is what they do. They support patients. And if you work as a team, you can say, okay, that works for that bit. What piece of kit have I got that will work with it? Children are always hard because we don't have many paediatric specialists. But we do have some. But I think the same questions apply about when you have got patients with contracture, with unusual body shapes. You've got to do your best to maintain the skin, because it's not just about the physical forces with them as well. You start getting kind of areas of body that you get maceration in, you get lots of fungal growth, you get all sorts of weird things. And we need to work much better at sitting down and saying, how will this work? What's your objective? What's my objective? Oh, they didn't work. Right, what's our joint objective? And I would really encourage that.
Thank you.
Great, thank you very much. We've got one more question and then we need to take a break. The lady in...
Hello there, my name's Pat O'Brien. I'm a physio and I work across nursing and care homes in Cornwall. And I just would like to say two things. One, it's dreadful to hear that my profession seems to be letting you down so badly in the hospital and the acute settings. And I have noticed over the past 20 years the withdrawal of bog standard physio input from care of the elderly wards. We're now getting clients back from hospital who have become de-skilled, disabled, when they've particularly gone to places where supposedly they're getting rehabilitation, which just doesn't seem to be happening anywhere at the moment down my neck of the woods. But that was always something that physios were trained to do. You get people up, you keep them moving, you look at positioning food just away from them, especially if they've had a stroke, you take it to the side that they're struggling with. Anything you can do to promote mobility. So that was my first point. My second one was, with all the best will in the world, where we are, the clinical responsibility for pressure seems to be being delegated to services that have no clinicians to make the decisions that are needed to be made. So I've been desperately trying to get appropriate seating into the care home that I cover, but I've been having to fight battles with the local loan store, who has now delegated this responsibility to care homes who mostly don't have anybody like me to help with these decisions. And we're being told to buy modular furniture, which we can just set for any of our clients. So there's no need for special seating, because actually your care staff can just take this bit off and add that bit on. And we don't have the knowledge, and we don't have the clinicians in our services to follow any of this up or review it or change it when it needs to be changed. So I feel there's a global delegation of responsibility to services which do not have in place those people with the knowledge to actually make the change. And that's different. There's also the issue of funding, of course, which is another big problem. But in the main, we have a lot of knowledge, but we don't have systems that allow us to put that knowledge into practice on the ground.
I think that certainly from the National Wound Care Strategy perspective, we are very aware of that. And one of the things we're trying to do is formulate pathways and start to try and gather data to see where the problems are. We're working quite closely with Enhanced Care for Care Homes, which is a national organisation, to try and look at what's happening with them. We're also working with ADAS, which is the Associate Directors of Social Care, because the point you made about funding, it's not just about I haven't got enough funding, it's about social services pay for the bed, health pays for the mattress. They're different sizes. There you go. There are lots of big system-wide issues that I think we really need to work on. And that a little bit is like starting to happen. And hopefully when we move more to ICSs, we'll see that happening better. But I think that even the people who are clinicians, where they are, the level of knowledge is still not joined up. So I think we need to come at it from lots of different angles. But yeah, I thank you for that. I think I really do appreciate that.